Hello, and welcome to this eHealth program on multi-cancer detection. My name is Dr. Candace Westgate, an OBGYN and cancer prevention specialist. I'm the medical director for the Adventist Health Early Detection Program, as well as chief of staff at St. Helena Adventist Health. Each of these chapters in this educational activity contains a supplemental video meant to give you additional insights and perspectives that put the scientific contents into a real-world context. We encourage you to read through the chapters and view the additional videos. So what gaps can MCED testing fill? We know that there's a significant unmet need for cancer screening and early detection. We only have 5 routine recommended cancer screening tests at this time. This was demonstrated to us in the National Lung Cancer Screening Trial data that was presented in 2023 ASCO conference that showed that 68% of the primary cancers found in the trial participants were cancers other than lung cancer. And that's what this trial was looking at, lung cancer. So that was really a mind shift and a change for me when I realized that even though I'm sending my patient for a mammogram, they have a higher risk of having a different cancer in their body than actual breast cancer. All right. So there's a significant gap, and we have an amazing opportunity with some of these new cancer screenings to step into a new arena when it comes to early detection and interception of cancer. Another concept is, as you all know, the number needed to screen. So with rare cancers, we need to screen a whole lot more of our patients to pick up just one cancer. However, if we instead are looking at screening an individual for multiple cancers at the same time, a number needed to screen is going to need to be significantly less before we're able to diagnose a cancer. Now, there's also patient barriers that we need to consider when it comes to the cancer screenings that we have even currently. The multiple appointments that they need, the fact that they're screening one cancer at a time, this places significant barriers to our patients of getting all the cancer screenings that we recommend. However, changing the opportunity here, where we can screen one patient for multiple cancers at the same time, this has the potential to reduce socioeconomic disparities for our patients and enable, hopefully, the opportunity to comply with these kind of cancer screenings and recommendations. Now, as you guys all know, the best screening for cancer is the one that our patients will do. So there is hope that the ease and convenience of a blood-based screening test could offer opportunities to improve access to screening for all of our patients in the future. So how are these tests performing? And how do we talk to our patients about this in a practical manner? And how do we understand it conceptually as well? So when it comes to our regular cancer screenings, and you're going to hear me use examples of what we know already in the space that we live in, like mammograms and colon cancer screenings a lot. An individual cancer screening, like a mammogram, sensitivity is very important, right? That patient is coming in to assess whether they have breast cancer. We don't want to miss a breast cancer, right? We now need to shift our paradigm and our understanding because we're in a totally different playing field right now when it comes to multi-cancer early detection. So we're screening one individual for multiple cancers. So if our sensitivity is very high, we're going to have a significant amount of false positives that come along with it. So when we're looking at multiple cancers at one time, specificity is much more important, that we're ensuring that we're not, we don't have too many false positives that come out with this. Okay, so that's how the test operates in the general population, right? The sensitivity and specificity of it. But when you're talking to that individual patient in front of you, a one-on-one discussion about what their individual test results mean, that's when positive predictive value and negative predictive value are the most important thing. So what's positive predictive value? So if our patients come back with a cancer signal of origin detected, what is the likelihood that after our diagnostic workup, we actually find a cancer, okay? Or what is the likelihood of that individual that gets a no cancer signal detected? What is the likelihood that they do not have cancer? Right? So this is talking about how the test is performing for that one individual, not in the general population. So with a multi-cancer early detection blood test, the importance is high specificity and high positive predictive value. So let's compare multi-cancer early detection screening and how well these tests are performing right now with our current standard of cancer screening. So take a look at mammography, even low-dose lung cancer screenings and pap smears. Their specificity is lower and their sensitivity is higher. The positive predictive value for a mammogram is around 4.4% only, whereas what we're seeing with these multi-cancer early detection blood tests is that the positive predictive value is ranging anywhere from 29 to almost 100%, depending on which test you're looking at. And the specificity associated with these tests is also in the upper 90s, which is very reassuring. The way I address apprehension from my fellow colleagues who are maybe considering starting to order these multi-cancer early detection tests for their patients is multifactorial. The first is that providers want to ensure that they're not ordering a test that has high false positive rates and putting unnecessary strain on the healthcare with the diagnostic workup, financial strain on the patients, but also anxiety for them. And here's where I review the literature and the data with these providers and show them the high specificity associated with these tests, which decreases the risk of a false positive rate, as well as the higher positive predictive value compared to where we live right now with our regular cancer screenings. What about a false negative, where this test is telling us no cancer signal detected, but the patient actually has an active cancer in their body? Well, we know that with any cancer screening, it's not 100% accurate. And so there is always that opportunity. So here's where I remind my fellow providers that this test is used in addition to and not instead of our current cancer screening guidelines. And this test needs to be repeated on a regular basis because it is just a snapshot in time right now for our patients, and obviously counseling the patients appropriately to the limitations of the study, that it doesn't rule out cancer 100%. What about the issue of potentially diagnosing a cancer that would otherwise not cause a problem? So we've learned a significant amount of this from PSA testing in the past with our patients, and we definitely don't want to make that kind of same mistake. And here's where the understanding the test that you're ordering and what their sensitivity and specificity is for those kind of indolent cancers is very important as you move forward with this. How do you, as a primary care provider, comprehend or start to think about implementation, and how do you implement this in your practice? So first would be to identify those who do and do not meet criteria for this kind of testing. So who does not? Those less than the age of 22, those that are currently pregnant, those that are actively undergoing cancer treatment, or those that are still within the 3-year window past their cancer diagnosis and cancer treatment. So who should we screen? As simple as everyone over the age of 50. We know that there's a significant increase in cancer risk over the age of 50, but you could also consider this at a younger age in those individuals who have a high risk of cancer. For example, significant environmental exposure. Think of firefighters. Significant lifestyle factors. For example, obesity, being a smoker or a history or having a history of smoking. Also, those with a strong family history, they are at higher risk. Or those with a predisposition gene, for example, the BRCA1, the BRCA2, or even Lynch syndrome. I want to now talk about 2 different case scenarios to help you put this into practice and see how this testing works in a real life situation. So our first patient is Layla, and she is a 47-year-old female. She has mild hypertension, but otherwise in really good health. Her BMI is 24. She does have a family history of breast cancer and a maternal aunt, but that breast cancer was diagnosed at the age of 77 and at stage 1. Layla is up to date on her mammogram, her pap smear, and her colon cancer screening. Is this someone that I would suggest talking to and offering her MCED testing? She's not at risk because of her age yet. She's not at risk because of her BMI or other lifestyle factors. Though she does have family history, it's not a high risk, with an older onset breast cancer. So based on the information that I currently have in this case with Layla, she is not someone who I would recommend this testing for. Let's look at Jack. Jack is also a 47-year-old male. His BMI is 31. His older sister was diagnosed with colon cancer at the age of 43. Thankfully, we know that she did undergo multi-cancer gene panel testing, and all of her colon cancer genes and the other cancer genes came back with no clinically significant mutation. Jack is up to date on his routine screenings, and for cancer for him, that includes a colonoscopy. Should I suggest MCED testing for Jack? So here is an individual who does not meet criteria based on his age, right? He's only 47, he's not 50. However, based on his BMI, he does fit into that elevated risk category. Based on his family history, he also fits into that elevated risk category. And so for Jack, this is an individual that I would recommend multi-cancer early detection testing for him, even though he's less than age 50. How frequently should you be rescreening your patients if their test comes back negative? Currently, there are no standard guidelines, and with more research, we'll be able to understand this more. But again, this is just a snapshot in time for our patients. So these tests do need to be repeated on a yearly basis or every 2 years, depending on the patient's level of risk. Or should it be every 6 months if they're at extremely high risk? So currently we don't have the data yet, but this is a very exciting field. What if the patient comes back, cancer signal detected? We do the diagnostic workup and we do not find any cancer at that time. Well, this is an individual who would really benefit from getting an additional test maybe 3 to 6 months later. This will be able to differentiate between a false positive test or no, that cancer signal is still there. This is a high-risk individual, and we need to keep watching them closely and consider repeating the diagnostic workup. What about insurance coverage? Is this something that is universally covered currently? No, it is not, but there are some insurance companies that are covering this, which is very exciting. My experience with the diagnostic workup and whether insurance will cover the diagnostic workup is actually being very positive. I really have not had a significant amount of pushback from the insurance companies. So far, I've only had to do one peer-to-peer, and at the end of it, it was approved. So all very positive findings so far. What do we do when we're interacting or referring our patients who comes back with a cancer signal detected to a specialist who maybe doesn't know anything about this test? So unfortunately, there is some education that you could be doing for these providers, maybe a phone call or a letter accompanied with your referral to them. There's some great data out there about these tests, their sensitivity, specificity, obviously, and the positive predictive value that would help the provider to understand the importance of a thorough diagnostic workup if there is a cancer signal found. Thank you for your time today. We hope that you found the information presented in this activity useful to your practice. You can also access the Clinical Resource Center for this program at www.exchangecme.com. There you will find key publications and other information on multi-cancer early detection testing and its integration into primary care. For additional CME opportunities, clinical resources, and links to patient education material, please visit us at www.exchangecme.com. Please subscribe to Exchange CME's YouTube channel and check back regularly for updates and new videos.